next question. This was easy, and this now we need to know, even it comes from the surgery, which one of the following factors would predispose a patient to forming keloid scars? So you all know about keloid, but what are actually, so which one for keloid predisposing factor we need to remember? So keloid is more prominent or more predominant in early adults, early adulthood, and that is basically 20 to 40 years. So that is 20 to 40 years here is very prominent. Apart from this, what else are prominent for keloid or predisposing factor for keloid? One is dark skin, and the second is this space. Second is male. Okay, and third, important location, sites of skeloid. So there are certain sites where we can find skeloid, and those are like this: sternum, then it can go to shoulder, it can go to neck, we can find it on face, and we can, then it goes to the extensor surface of our limbs, and last it can come to other places on the trunk that we need to know. And what is the treatment? As per the NICE guidelines, there are two intervention we can give for the keloids. One is the intralesional steroid or intralesional triamcinolone, and the second one, definitely we can go for excision and secondary incision. Through that we can go try for a cure towards the keloid. Coming to the next one, the 32-year-old woman has noticed painful lesions on both her shins in the past 2 weeks. Already we understand what it is. So she is currently 18 weeks pregnant and reports that she was treated with a course of cephalexin for a urinary tract infection 3 weeks ago. She also has a history of hypothyroidism and increased her levothyroxine dose in her first trimester. That is actually required, and normally the thyroxine dose increases in the early pregnancy. That's completely normal. And after her normal means that's completely usual. And after her blood test indicated she was undertreated. Okay. In addition, she has irritable bowel syndrome, which is well managed at present. She smokes 2 cigarettes a day. On examination, there are multiple erythematous nodular lesions distributed symmetrically on her lower legs, every one measuring around 1 to 5 centimeters in size. So which part of her medical history is most likely to have caused her dermatological condition? So first we need to know what the dermatological condition is, and this is erythema nodosum. That is basically erythema nodosum. So that is basically inflammation of subcutaneous inflamed subcut fat. So it's a panniculitis, basically subcutaneous fat inflammation. And remember, very important, that most important reason in this particular picture points towards the pregnancy. Definitely certain drugs like penicillins or certain combined OCP, they can point towards the erythema nodosum. It can also happen in certain disease like Behçet syndrome or sarcoidosis. All we have discussed in the last thing, and these are tender nodular swellings are present, or basically in erythema nodosum that we can find. Two more important, hypothyroidism can be rarely associated with erythema nodosum too. That is also correct. But here, say she was hypothyroid beforehand. So that is not a new phenomena. So that is not causing her erythema nodosum. It is caused, it's a new onset erythema nodosum, and that is caused by her early pregnancy. So that gives the answer. Few important things. She has IBS. Remember two things. IBD, inflammatory bowel disorder, Crohn's or ulcerative colitis, can be associated with erythema nodosum. But remember, IBS, irritable bowel syndrome, it is not connected to erythema nodosum. This is another thing that you need to remember. And regarding the drugs, already we have mentioned Silins, sulfa, OCP. They are notorious for erythema nodosa. Moving to the next one, slightly different, and we didn't touch this part in last class. 64-year female referred to derma due to a non-healing skin ulcer on lower leg. So our DD becomes shortened, and this has been present for around 6 weeks. So definitely non-healing for 6 weeks, and appearance didn't improve following a course of oral flucloxacillin. So it's not a cellulitis or anything infective. So which of the following most important investigation to perform first? So we need to understand whether there is some kind, whether it is a venous ulcer or whether it is an arterial ulcer. That's the first thing, and then we will move on. See, like X-ray or osteomyelitis line or swab or culture sensitivity, those things are already excluded because she is not responding to this. And definitely rheumatoid factoritis, it doesn't usually comes up like a non-healing ulcer. So the most important here is, which will give us an idea about the arterial or venous insufficiency, that is the ABPI, ankle brachial pressure index. Remember, why ABPI? What is the actual indication, or how ABPI helps us? ABPI helps us to exclude arterial insufficiency. Arterial, because from her presentation, it is clinically felt that this can be a venous ulcer, because already we have given the thing. So if it is a venous ulcer, then our line of treatment will be compressive bandage. Now, if the patient has arterial insufficiency, we cannot use compressive bandage. So for that, we first have to check for the ABPI and normal ABPI. Now, what is the value of the ABPI? The normal is 0.9 to 1.2. And if the value is less than 0.9, then we can say that the patient is arterial disease, peripheral arterial disease. Again, another important thing, that if the patient has more than 1.3, then again patient may have arterial disease. This is a false negative test. More than 1.3, ABPI more than 1.3 is common if there is calcification in artery, which is very, very common in the diabetic mellitus patient. So this one you must remember. So 0.9 to 1.2 is normal, you can compress. 1.3 more than that or less than 0.9, now you have to go for further examination. Arterial insufficiency is already there. So other imaging and other things we need to go on. Okay, and if it is a venous ulcer also for MRCP part 1, most questions, they point to the question like that. There was a typically seen above the medial malleolus. So that is another thing that you need to understand. So what is the management of the venous ulcer? Venous ulcer management is compression bandage. Basically 4 layers are to be given or are to be applied. Compression bandage, 4 layers. Some evidence are there for oral pentoxifylline. We can go for oral pentoxifylline. And some evidence for flavonoids are present. There is no evidence, or very, very little evidence for hydrogel or hydrocolloid dressing. These pinks are very, very little thing. Or ultrasound therapy, these are very little evidence. So mostly if question comes for venous ulcer, which is the least applicable method, then this pink zone may be helpful, which is not in this question. Now moving to the next one. 17-year-old man presents with a 2-week history of abdominal pain, diarrhea, repeated episodes of flushing. Examination reveals arterial skin lesion on the trunk. So what test is most likely to reveal the diagnosis? So what do you think? See, there is abdominal pain. Now this is tricky question. Abdominal pain, age is 17, history is for 2 weeks, diarrhea is there, and repeated episodes of flushing. It can go into pheochromocytoma, it can go into carcinoids, everywhere it can go. But very important is he has, which is quite new basically, which is quite standing out kind of a thing is that arterial lesion on the trunk. So that is basically not present in those carcinoid and other VI-poma, all this scenario. So this is something else. So the actual diagnosis where you can find this kind of neuroendocrine-like features along with urticaria or skin lesion is systemic macrocytis or macrocytosis, systemic mastocytosis, systemic mastocytosis. Okay, and how you can basically treat or how you can gauge whether this is a systemic mastocytosis. First of all, what is systemic mastocytosis? It is basically abnormal proliferation of mast cell. The mastocytes are mast cells. So abnormal proliferation of mast cells. And if anywhere in suppose in the skin, if you have a mast cell abnormal proliferation and if you scratch it, then mast cell will be stimulated, and you all know that if mast cells are stimulated, they will secrete histamine. Once histamine is secreted, so what will happen? Histamine will call local flare and it will call local itching more and more. That will be a linear well-like lesions will be found in such scenario. This particular lesion in mastocytosis is known as urticaria pigmentosa. Urticaria pigmentosa, where we can find some rubbery welt on skin along with, in this disease, along with abdominal symptoms. So how we can identify this? We basically identify this with urinary histamine. That's the answer over here. We identify it, urinary histamine. Another very important thing that you need to remember, that why it is not carcinoid, though it is very close to carcinoid. Remember, the mean age for carcinoid is 61 years. So it is not a disease, usually not a disease of young adults, where this I have already highlighted over here. Okay, we'll also discuss in another MCQ, we'll discuss more about this.